Welcome back. After the lunch, 49th Sri Lanka Surgical Congress organized by the College of Surgeons Sri Lanka in collaboration with the Royal College of Surgeons of Edinburgh and the SARC Surgical Care Society. This is the afternoon session of first day of our main session. I would like to invite you to join our next event, a symposium on spine and future. I would cordially invite Chairperson Dr. K. Umapathy, who is consultant orthopedic surgeon, National Hospital Sri Lanka, and Dr. Romesh Goonasekara, consultant plastic surgeon from Leclercq Hospital, Sri Lanka. Over to you, sir.
Good afternoon, everybody. Welcome to the Symposium on Neuroplastic and Orthopedics. And we'll start the symposium first. Dr. Romesh Goonasekara will introduce the first speaker.
Thank you, everybody. Welcome. And, can you hear me, Uma?
Yes, we can.
The first speaker is going to be Dr. Caroline Leclercq of the Institut de la Main of Paris. And she's a hand surgeon who specializes in the spastic hand. So we will, she's online, but we will hear her video starting now. Thank you.
Good morning. This is Dr. Caroline Leclercq speaking from Paris, France. And we will be spending a little time on the means to restore the function of upper limb in tetraplegic patients. I'm not sure about the numbers in your area, but in Europe you can see that there is 16 new patients per million inhabitants and per year. The main cause of tetraplegia is a motor vehicle accident, then diving. And you can see that bullet wound is at the bottom of the list, which is unlike countries like the United States, for instance. So what is tetraplegia? It's a lesion of the spinal cord at the cervical level, which induces a complete paralysis of the lower limbs, but only a partial paralysis of the upper limb. So it's important to understand from the start what is the level of injury, what we call the injured metamer. And you can see here the typical motor column arrangement that we all pretty much know. And of course, it's not the same to have a cervical lesion at C5 and C6 level with a patient that has no function of the hand whatsoever, electric wheelchair, and as the lesion is lower, you see that the patient can have some function, can go down to manual wheelchair, and finally can use his hands partly with a better autonomy. So we have along the years, along with our former colleagues, built up an international classification. It was actually decided in Gien, which is in France, in 1984. And you see this international classification with key muscles remaining active and strong. And this is how we build this classification. So how can we help these patients? Well, basically, there are three types of procedures that we can perform. Tendon transfers, of course, every time there is remaining muscles, but we also rely on tenodesis and sometimes on arthrodesis. These are very well-known procedures now. There is abundant literature since the 70s, and this is a book that we wrote with Dr. Hans almost 20 years ago, and the principles have pretty much remained the same. First thing we need to wonder is there elbow extension? This is mandatory, because without elbow extension, the patient will not be able to use his hand to interfere with the environment, even though he has a good hand. And also on a technical point of view, we need to stabilize the elbow before transferring any muscle to the wrist and the fingers. So how do we do this? There is basically two types of procedure. First one was designed by Eric Moberg, and it's a transfer of the posterior part of the deltoid to the triceps. There is a need for intercalated grafts, and you see there are several solutions for that. The second type of surgeries was promoted by Zancoli and consists in transferring the biceps to the triceps. Whatever choice we make, the post-op regimen must be very strict with 4 weeks of immobilization, then progressive flexion, roughly 10 to 15 degrees per week. Failing to do so, the result will not be optimal. And the results of this type of surgery can be quite good, as you can see here in this video, with excellent elbow extension and muscle strength up to 4 or 4+. The functional results of this type of operation, as we said, was a large increase of the space of prehension, which has been calculating and facilitating manual wheelchair. It's also very much appreciated by this patient that they can go back to some leisure activities. Now, how about hand function? Well, again, we're going to go through the metameric level. The first group is group 0 with no muscle below the elbow. Unfortunately, there is not much we can help them with. There was some experience with functional electrical stimulation in the previous years, but this has been stopped for the moment. In the next group of patients, group 1, you see that those patients have retained mostly elbow flexion and a brachioradialis muscle. What can we do with this brachioradialis muscle in order to help them? You see that their function is very poor. They need adaptive devices for all activities of daily living. And it's pretty much Eric Moberg who has explained to us that with this brachioradialis, instead of trying to transfer it to the fingers, we need to re-establish the so-called tenodesis effect. And you can see here the concept of tenodesis effect. When the wrist is brought into extension, then there is an automatic pinch between the thumb and the index finger. So in this group of patients, this is going to be the scope. And this is a drawing by Eric Moberg himself. So the brachioradialis is transferred to the wrist extensors. And in the same procedure, we create a passive tenodesis between the flexor pollicis longus and the radius. There is a need to stabilize the thumb, either MP or rather IP joint for a better pinch. And this is a result of this procedure. And you can see that active wrist extension is going to put the thumb in a strong position against the index finger. And of course, the patient needs to activate his wrist extension in order to produce this strong pinch. Next group of patients, group 2. In this group, the patients have not only the brachioradialis, but also some wrist extension. It's not too strong, but it is present. In this case, well, the brachioradialis can be used for another function, and the goal here is going to re-establish an active key grip. The brachioradialis is going to be transferred to the flexor pollicis longus, and again here we need to stabilize the thumb IP joint. Otherwise, we have the risk of creating hyperflexion of the IP joint with a poor pinch. The next group, which is the most frequent, is actually the next 3 groups that we're going to deal with together, the groups 3, 4, and 5. And the patient has brachioradialis, strong wrist extension, and in the lower 2 groups, he also has pronator teres and flexor carpi radialis. The scope here is in this patient who already have a tenodesis effect, because they have good wrist extensors. And this is how they function with very light adaptive devices. They have good control of their wrist. And so those patients are usually in a manual wheelchair, and you see that they can push the wheelchair with the sole of the hand and not with the fingers, which is not extremely convenient. So the scope here is going to be using the muscles available, namely brachioradialis and one of the two wrist extensors, and maybe in the lower groups, the pronator teres. And we are going to restore some extension of the wrist and grasp and pinch. As opposed to the previous group, we can restore both functions. So how do we do this? 2 surgical steps. First, the extensor phase. It's usually a passive phase, and we tenudise the finger extensors to the radius. So the passive phase first, and the second phase is the active phase with the ECRL transferred to the finger flexors and the brachioradialis transferred to the thumb. We need to do additional procedures, and we won't go deep into that, but suffice to say that there is a need to fuse the CMC joint to stabilize the thumb column, and also to do some intrinsic procedure in order to avoid clawing on the fingers. And we usually choose a lasso procedure designed by Zancoli. Between the 2 surgeries, there is usually 2 to 3 months. So you see, it takes a long time to restore a hand. This is the type of result you can get. This is pre-operative, no strength, good tenodesis effect, but no strength in the pinch. This is post-op, good opening and closing of the hand, excellent pinch and grasp. And you see here the strength of the thumb with 1 kilo force. This is the kind of things that the patient can achieve post-op, and you see that they can grasp the hand rail of the wheelchair. Should we operate only 1 hand or 2 hands? Well, there's a number of activities, including self-catheterization, which is very important for these people, that makes it worthwhile to restore 2 hands. Briefly, the next group is our group 6 and 7, with patients having retained wrist, finger extension. When in this case, things are easier. It needs to be said that those patients do not function as well as the previous group because they have this flat hand, and their tenodesis effect is not very good. And the result of surgery in this type of patients is really, really satisfactory. So 1 transfer to the finger flexors, same scheme as previously, brachioradialis to the thumb flexor, but this is done in 1 step because they already have some finger extension. You can see how strong the grasp is after this type of surgery. This is 4 months post-op, and this is a pinch. If it works, here we go. And you see this patient states that he has improvement in writing, feeding, dressing, manual wheelchair, transfer without the board. Sometimes we can do even more refined procedure when there is extra muscles available, and you can see here that the EDM has been transferred for a subterminal pinch. The last groups we won't go into, they are rare, and the procedures that we use in these patients are similar to distal median and ulnar palsy. So when can we operate these patients? Well, we need to wait until they have recovered all the muscles they need to recover, but also make sure that the general condition is satisfactory and they have accepted the permanent state of paralysis that they have. And this is not always easy. Which patients should we operate? Well, just about everyone who has some active control in the forearm muscle is a candidate. Of course, there are a few contraindications. Sometimes they are spastic severely, sometimes they have stiffness, but I think the most important contraindications are either patients who are not motivated, but mostly those who expect to restore a normal hand. the surgeon here is only one part of a team, and this needs to be a teamwork. That's extremely important. So as a conclusion, this takes time. It's long to restore two hands function. Of course, it's far from normal. The improvement will not be spectacular. However, those procedures are reliable. They facilitate activities of daily living, and most of all, and this is always our scope, they increase the independence of these patients. Thank you very much.
Thank you very much, Caroline. Thank you very much for the better insight into this. Our next speaker is Dr. Dilshan Munidasa, who is a consultant orthopedic surgeon at the National Hospital of Sri Lanka. Dr. Dilshan Munidasa will be talking to us on future of the spinal surgeries. Over to you, Dilshan.
Thank you, Dr. Umapathy. In this presentation, I'm going to speak on the future of spine surgery. In my presentation, I mainly focus in the fields of degenerative spine and surgical technological advances that could predict to come in the fields of management of spinal disabilities and scoliosis. The advances of early decompression and spinal cord injuries have been well established, and all recent meta-analysis shows that early decompression would protect critically injured zone in the spinal cord injury. The technology advances of the stabilization will be discussed later in the presentation. Therefore, we mostly talk today, as far as the spinal cord injuries are concerned, are in the fields of molecular biology, cell therapies, and nanotechnology, and those will be discussed by the next speaker in the presentation in this symposium. As far as the spinal fusions are concerned, one of the promising advances in the spinal fusion is the use of electrical stimulation to the bone graft to enhance fusion. In this study conducted by the Johns Hopkins University last year has evaluated 16 such studies, and it has been found that it is effective only when electrodes are implanted next to the bone graft, but not when those are worn outside the body. Now let me come to technological advances that are advancing in the degenerative spine, osteoporotic spine, and scoliosis correction surgery. Firstly, when it comes to degenerative spine, use of biological agents in degenerative disc disease are being studied as a novel therapeutic option. These agents are injected to the space either to halt degeneration or to initiate repair. There is a recent study published this year in current reviews in musculoskeletal medicine, which has shown it is to be a success. Cervical disc arthroplasty, not new. Sri Lankan experience in 2011. This is a poster, that's why it is so crowded. This is a useful tool in relatively young patient. In these replacements, it is well known to prevent adjacent level degenerations in contrast to anterior cervical fusion. This was not popular due to high costs and dislodgement of the implants in the past. Now, with new low cost implant and advanced designs, it is being gaining popularity now. Lumbar disc arthroplasty again was not much popular due to higher complication rate. However, new third generation implants in selected patients, it has shown clear benefit over spinal fusion. This study was published in February this year in Neurosurgery Journal. When it comes to osteoporotic spine, hypoplasty is a viable option. This is again a poster. However, it was not much popular due to complications associated with difficulty in finding the transpecular trajectory. But thanks to navigational technology, with improved devices, it is becoming more popular. So this video will show it is done under sedation. Here, spinal trajectory is trajectory is formed, and balloon is inflated within the vertebral body, and then those are withdrawn, and to to the so created space, the bone cement is injected. And once those are solidified, it adds stability to the spine, making it immediately postoperatively less painful. And this is the postoperative image. Now, let us now see what are the technological advances that would come up in the spinal fusion. Robotics. In contrary to popular belief that robots are performing the surgery, it is more of a guidance made by the robot for correct screw trajectory. There are multiple advantages of using robot for screw replacement, and it is very much less X-ray exposure to the surgeon, and surgical plan can be customized to the patient. And studies have shown that high accuracy of screw placement up to 98.3%, and it is quick and very much less complications. So this video shows how robotic technology is being used in spinal fusion. You can see here the very much minimal staff involvement. Screw trajectories are adjusted in computer-generated image on the screen, both in coronal and sagittal planes, and on the axial view as well. And then guide pins are inserted along the created trajectory, making drill holes, and screw placements is done by the surgeon. It's happening in very relaxed environment. You can see the surgeon is in very relaxed mood. And this, once the trajectory is completed, screw placement is done by the surgeon. So this is the 3D image of the screws, and that's how the screws are being placed. And once the screws is placed, and the robot automatically position itself to the next position, and then the surgeon perform the drilling and screw insertion. So coming to scoliosis surgery, traditionally there are 3 methods of management of adolescent scoliosis correction, depending on the severity of the Cobb's angle. The methods are initially for the less degree of Cobb's angle, for that is physical therapy and exercises. Then the next level is bracing, and then finally, if the Cobb angle is very severe, it's scoliosis, fusion surgery. And now we have additional method, that is method in between the fusion and the conservative method. Let us see what this method is. In this video, the fusion-less correction of scoliosis is seen. In this method, transpedular screws are fixed using minimal invasive technique, and onto which a special device called epifix is inserted. Screws, then it is aligned, then the nuts are tightened, and that's all. Then the surgeon comes out of closing the skin, and after about post-operative 2 weeks, the patient performs specific type of exercises so that its inherent ratio mechanism come into action and make the correction in the post-operative days. And you can see how it corrects on its own with the movement of the spine. So in this method, the surgical time, hospital stay, and incision length is significantly less than open surgery, and also much more comfort to the patient. Now let me come to spinal navigation. It has been the talk in most recent conferences. The problem with minimal invasive surgery is poor visualization of screw trajectories. This has now been overcome with combining minimal invasive surgery with spinal navigation. Now, let us see this video, how it's been done in a patient with L4-5 instability with neurogenic claudication. Very small incision and happens in a much more disciplined environment, and the C-arm is being placed, and you can see the initial X-rays are taken to place, and the C-arm records about 100 X-rays without anybody in the theater, and then the surgeon registers certain instruments which are necessary for screw placement, and then the surgeon finds the screw trajectory, and then with the use of conventional registered instrument, the opening of the entry point, and then insertion of the screws. So once the screws are inserted, the rods are being inserted with a specially designed jig, and the top screws are fixed. And then once that is done, the jigs are removed, and the same thing is done on the opposite side. And this is how the things are being removed, and very small incision, less pain. In Sri Lanka, we are not far behind the international advances. In this case, there's a test series of 60 minimally invasive spine fusions were analyzed, and this group was compared with 48 patients who underwent open surgery. The comparisons are made using Osteoporotic score indexes. The blue line represents the preoperative scores, and the orange line represents postoperative scores. This is a graphical comparison of the overall Osteoporotic scores in the two groups. There are statistical significant improvement in Osteoporotic parameters in the navigated group. The study concluded that navigated minimal invasive surgery patients had less hospital stays, less blood loss, less post-operative pain, and proper pain medications, and they are fast to go back to normal activities, and it's very cost effective. So finally, the take-home message: future advances technologies would help reduce time and cost and provide optimized outcomes in spinal surgery. As technology gives successful outcomes, when more innovative technologies continue to develop, intelligent orthopedics, a combination of traditional and techniques and high-end technology with neuroplastic orthopedic confluence will be the future of spine surgery. Thank you, and stay safe.
Thank you very much, Dr. Dilshan. Thank you very much for the excellent presentation. Now we'll be moving on to the third topic. The third topic is going to be presented by Dr. Rathugamage. He'll be talking to us on new therapeutic modalities for functional restoration of spinal cord injuries. Dr. Rathugamage is a consultant neurosurgeon at the National Hospital of Sri Lanka. Over to you, Dr. Rathugamage.
Thank you, Dr. Umapathy. Good evening to everybody, and I will outline my presentation with the content of short introduction and the standard approach for any spinal injury with some therapeutic goals, and then I will talk on steroids, therapeutic modalities available as surgical, and new therapeutic modalities which are helping for functional restoration. So this is a summary of my presentation, but I will come up in later. So most traumatic spinal cord injury studies showed bimodal age distribution, which arise as a result of mostly the road traffic accident. And many seeks in our country Ayurvedic and homeopathic or a native treatment. As such, we don't have proper statistics. So spinal injury registry is a must for us to have in order to get the proper statistics. So the most important part of this issue is most of the involved patients are breadwinners of the family, and it is a socio-economic problem rather than a health issue. Bring them back to the family and the society with regaining functional capacity is our mission, and that should be gain as a teamwork involving many people around the healthcare system. In recent years, we have made a considerable advances in this treatment of spinal injury patient. So two groups which I just go on primary injury and the secondary injury, dividing, because primary injury is as a result of a direct force, and the secondary injury is caused by the vascular changes following trauma, forming free radicals, calcium distribution changes, and the participation of opioid receptors and the inflammatory process. So standard approach to the spinal cord injury is a safe evacuation, safe transportation, assessment and treatment of airway, breathing, circulation according to the ATLS guidelines, and maintaining the at least minimum of 90 millimeter systolic blood pressure, and proper neurological assessment with ASIA grading and ASIA impairment scale, and then prevention of complication with the spinal immobilization, especially the bed sore and the DVT and the other respiratory complications. And this is the chart which we are using normally for ASIA grading. And so it has recommended the following scale assessment for motor strength. And then ASIA impairment scale comes modified from the Franklin classification. A, B, C, and D, and E. A is complete and the E is normal. So treatment goals in neurogenic shock, I will outline. The most important treatment consideration is to maintain adequate oxygenation and perfusion to the injured spinal cord. Supplementary oxygen or even sometimes mechanical ventilation is necessary, and the heart rate should be maintained about 60 to 100 per minute. And initial fluid resuscitation, hemodynamically significant bradycardia should be treated, and urine output should be maintained with the Foley catheter, and also it will helpful for to decompress the neurogenic bladder, which is most common thing in spinal cord injury. And rarely inotropic support with the dopamine or a norepinephrine is required, and dopamine, a small dose of from 2 to 5 micrograms will be enough to maintain the necessary blood pressure. The lot of controversies are around steroid use, but the recent guidelines with regard to the methylprednisolone has been gone on with many studies, including NARCISS 1 and 2, and the recent advances has shown that incomplete cervical medullary lesion in patients with cervical spondylitic myelopathy have a very good impact on methylprednisolone infusion, and they have specifically outlined the time gap. It should be less than 8 hours, and the first 3 hours of spinal cord injury, methylprednisolone should be infused with the dose of 30 milligram per kg or 15 minutes, followed by 23 hours of continuous infusion of 5.6 milligram per kg per hour. And for the 3 to 8 hours, only the difference is a continuous infusion of 5.4 milligram per kg per hour. So dexamethasone is indicated in patients whom methylprednisolone cannot be given as a non-availability or as the delayed treatment, and it has shown in vitro studies that the dexamethasone inhibits the level of autophagy and the injured nerve cells in dose-dependent manner. And high doses of dexamethasone protect the damaged spinal cord neurons by inhibiting apoptosis, but a protective effect is low dose in dexamethasone is not obvious. So ganglioside or GM1 is also being added in order to get the early recovery from the neurological deficit. And erythropoietin also has shown, but it has not shown any functional outcome difference with regard to the spinal cord injury. However, it will reduce the medullary cavitation, cellular infiltration, and neuronal cell apoptosis. Mannitol is always been used in the past for brain injury, but now it has been shown that in spinal cord injury, it will in the absence of contraindication, it can be safely transfused and it will improve the secondary spinal cord edema. Hypothermia is currently being advised in order to bring the systemic treatment as a systemic treatment if there is no contraindication, and it will decrease the metabolism of injured tissues and reduce oxygen consumption. And it could be infusion of epidural space also can be done, and I will talk at the last slide. So main goal of this spinal cord injury management is a decompression of the external element, and primary purpose in the management of patient with the acute spinal cord injury. Currently, little attention is paid to the potential deleterious secondary effect, and therefore my main aim is to focus on decompression. Spinal cord injury related cord swelling is any sustained external pressure may block normal cerebrospinal fluid flow and further increase spinal cord edema. So myelotomy. Myelotomy is early debridement of necrotic tissues, which will benefit by preventing complete paralysis. It reduces the pressure of the spinal tissue and the CSF preserving and surviving axons, and spared spinal cord tissues and delaying glial cell death in white matter, thereby providing a more neurological recovery and reduced fibrosis. The two scenario I will discuss. One is a patient whom I have done only decompression and fixation, and the other one with the myelotomy. And this is Mr. N, admitted with sensory level of T10, and T12 corpectomy and fusion was done using 11th rib approach, posterolateral thoracotomy, extraperitoneal, extrapleural approach, and interbody space is gapped with 11th rib resecting into 3 pieces. And 70 millimeter lateral plate is being fixed with 4 screws. You will see the injury, and so extent of the injury you can assess from the sagittal as well as the axial. And this is the decompression and fixation is done. On lateral view, you will see that the placement of a rib prosthetic material. The second scenario is Mr. K, and again having a spinal injury with the sensory level of T12. L1 corpectomy was carried out with rib-based 12 rib-based posterolateral thoracotomy, and again extraperitoneal, extrapleural approach. And in this patient, he had a damage to the PLL as well as to the dura. And during the surgical procedure, I have done a debridement of the spinal cord. You can see and have some idea about the impact of the injury. And this is the CT for me to show you the extent of involvement. Anterior column, middle column, and the posterior column, all 3 have been involved. And this is the fixation with the using a mesh cage with the bone graft harvested from the patient itself, and 4 screws are being placed. And this is the recovery.
Dr. Rathugamage, you have 1 minute more.
Yeah, and so I will skip some of the guidelines, but early decompression, as my colleague has said, is giving benefit and improvement of the Asia grade 2 in scale. The other things which I will discuss is cell therapy, and olfactory enhancing cells are being used for partial function or quality of life is being improved after injecting into the parenchyma or intrathecally or a lesion area or lumbar subarachnoid space. Other cells are being used bone marrow for hematopoietic stem cells. Umbilical cord blood mononuclear cells or bone marrow mononuclear cells and embryonic stem cells are being also used. Neurotization or nerve bridging also been done in the past and also now currently practiced. And our first lecture, it has been mentioned a little. And electric stimulation therapy is also advisable for these patients, and it will stimulate and improve the axon regrowth. Other advances in spinal cord stimulation, which are being found to have as a side effect or a placing for a what you call failback syndrome, and then diaphragmatic pacing patients with the high cervical spine injury, use of robotics in accurate placing, as my colleague has already mentioned, advances in neuro rehabilitation and active or passive physiotherapy using robotics, and example is the exoskeleton. Spinal cord stimulation is the equipment used for a failback syndrome. And
thank you very much. Timing is up. Can you summarize?
Yeah. And so
the
exoskeleton. In summary, so advances of in neuro spinal cord injury is been advancing rapidly in the last couple of years, and especially with regard to the decompression, we have to take much of a concern and help for the development of spinal care. And I will go back to my first slide.
Thank you very much, Dr. Rathugamage. Right. We have one question. The question is directed to Caroline as well. The question is, what is the composition of multidisciplinary team to manage a quadriplegic patient?
This is a very good question. The surgeon is only one link of this group, and the most important people are the team in the rehabilitation centers, and that includes physiatrists, physiotherapists, and occupational therapists. In my view, the occupational therapist is a very, very important part of this group of people.
Right. Then that's the question from me. What will be the timing of intervention of each of these category of people? The surgeon anyway comes early on.
So usually I, as a surgeon, I'm asked to see the patient after 6 months after the injury. I have to say that one element which I did not mention in my talk is this new field of nerve transfers. We are starting a new experiment, new experiments of nerve transfers in tetraplegic patients. In that particular group of procedures, we need to see the patients earlier. So if we are to deal with nerve transfers, we might want to see the patient after 4 months. If we do the classical procedures, tendon transfers, it's fine to see the patient after 6 to 8 months and plan the first surgery after 1 year.
Thank you very much for that information. With my co-chairperson, Dr. Romesh Goonasekara, I take this opportunity to thank all the speakers, Caroline, Dr. Dilshan Munidasa, and Dr. Rathugamage. And it has been a wonderful symposium, and thank you very much for all. Thank you. We conclude this symposium at this moment.
Thank you.
Thank you.